Good afternoon. Thank you guys for coming. I appreciate it. What we're going to do today is to begin a lecture series about how to care for people with disabilities of all different kinds. Give you a little background on me so that you know who I am. My name is Ava Stanzak. I'm an osteopathic pediatrician, and I've been caring for people with disabilities for about 40 years, 40 plus years of all kinds, of all ages. And as a result of my experiencing people with disabilities of all kinds and caring for them, I actually put together a book on how to do it since it doesn't seem to be present in medical education. And many people go into primary care and they encounter many people with disabilities, and they really are unsure of what kind of care they need, who their caregivers are, and how to interact with the patient, the family, and the rest of the medical community. So hopefully this will give you some insight on some things that you might want to learn in order to be the best primary care physician you can. Some things we're going to talk about include discharge planning. That's another thing that they mentioned this to you in medical school, how to do a discharge summary when you're on your third year and fourth year rotations. They don't really tell you what needs to be in that. That is usually left to the nurses to take care of sometimes. Sometimes it's one size does not fit all. Different people need different things when they go home, and some don't go home. They might go to a rehab center, they might go to a different type of hospital, or they may actually go home. You need to figure out what the family needs because there's a family there. A few times there's not, but usually there is, or some sort of regular caregiver that's going to interact with the patient every day. They need some training before they take their person home because many of these people, and we'll get to this in further lectures from now, have different kinds of equipment that they may be totally unfamiliar with. They've never seen even before, and they need to know how to use it. You need to evaluate what the specific needs of the patient is prior to going home. It's not going to be different. It's not going to be the same for everyone. So you need to really get to know your patient and their family. And I'm going to talk a little bit today about how to build the team, because this is the most important part of getting ready to send someone to either another facility or definitely home. And how to navigate the initial patient encounters, because they can be a little bit different. So what about going home? It's usually a happy time because some people have been in the hospital for an extended period of time. The longest I had a patient have to be in the hospital was their entire life up to age 4. They never went home. And in fact, the patient's parents found me through the network, if you would, and called me on the phone and said, can you please get my child transferred to a hospital from which they can go home? And it was all in the same town. It's just they had kept this child in the ICU for 4 years. Well, sometime we'll talk about what that does to a human being if you're in the ICU for 4 years. But this child had never gone home. And he had cystic fibrosis, multiple other problems, and some heart disease to go along with it. But they wanted him home, regardless of his condition. So we got him transferred to Children's in Dallas, and we finally got him home and ended up making home visits. By the way, that's another lecture. But you need to find out what has happened in the hospital while this person was there. And you need to decide when they're stable enough to return home. The last thing you want to see is an unstable patient go home. You've got to get physicians. The physician has to be involved from the get-go, from the very beginning. You cannot send someone home. They should not be sent home from the hospital with special needs unless there is a one physician and one office that's going to oversee all of their care. The big health care centers, the big tertiary care centers don't do this. They're say, okay, Johnny Jones is going to be discharged next Tuesday. And they expect that because after that time, it has already been ascertained that they will not get paid by the insurance company after a certain time. So they have to go home. Now, if they're not stable enough to go home, the physician that's caring for them in the hospital has to say so that they'll extend their stay. But many times a care team or some other entity has created some sort of a discharge plan for this patient. Sometimes the family's not included, just so you know. Sometimes they don't even know until the nurse comes in and says, or the attending in the hospital says, oh, by the way, they're going home next Tuesday talk about panic. These people, they lose it right there. I know I've been in the hospital when that's happened, and it's not fun. So the parents and caregivers got to be made aware of this, and they've got to start looking for a physician to take their person's care. And it unlikely nowadays will be the one that cared for them in the hospital, because now we have hospitalists, which by the way, we haven't always had. And the hospitalist has taken care of all this person's inpatient care. So that's all they know. There's got to be somebody on the outside that's going to take care of them after they leave the hospital. And that's why you have to have a physician. The parents and caregivers have to choose some sort of a physician to be what I call the ringleader of the whole thing after they go home. Can also get social work involved, especially in the big hospitals. All hospitals have social work, but get that person who they probably have already someone assigned to them, get them involved in helping for the search. And we're going to talk a little bit about how caregivers, patients, and parents can pick a physician. Here are the components of the team, and this is what you should be looking for in a team that you use to send a patient home from the hospital who has special needs. You got to have a purpose and scope. You got to get the right team members, and this is huge because not everybody's a good player. And you have to have a collaborative, communicative environment where everybody's talking to everybody. You can't have physical therapy over here and speech therapy over here and maybe home nursing over here, equipment person over here. They all have to be able to talk to each other. So it's really hard to find those groups. What we did in our office, I thought was beautiful. We actually had what we call the Allen Pediatrics cheat sheet, where we had everybody we used on a paper with their phone numbers and the contact person. So as soon as we got a person with special needs, we know who to call, where to call, and all that. And these were people we had already used previously. We already knew they took all the insurance plans, and we also knew that they were going to take good care of our patients. Now, on the other hand, if a parent or caregiver came in the office and said, or the patient himself came in and said, I went to such and such, that was the most horrible experience of my life. Please don't make me go back there. Boy, they went off our list in a heartbeat. And that's when we still had whiteout. Okay. Whited them out. We found somebody else. Takes time. It's got to have a focus on patient-centered care. It's all about the patient. It's not about you. It's not about the physician that's caring for them. It's not even about the family. It's about the patient. And you have to have a continuous improvement plan, things that don't go so well, to make them better. Here are just a few of the things that caregivers, patients, and parents encounter when they take a person home who has special needs. They have to learn they have to learn what this stuff is before the patient ever goes home. Most people have never seen a urinary catheter. Many people have never even seen an IV. And certainly they haven't seen endotracheal tubes and portacaths and PEG tubes and all this other stuff. It's totally foreign. And so you cannot send someone that has these devices home until everyone who's going to be involved with that person learns what it is, why it's there, how it works, and what happens if it falls out, because that's scary. If you can educate the caregivers and the patient, now patient many times can do some of these things themselves, but sometimes they can't. So you have a caregiver that's going to do it. And it could be a parent, it could be a family member, it could be their best friend, it could be a neighbor. Everybody has somebody else. They're not necessarily family members, but they need to be trained on how these different devices work and what to do should they become dislodged or malfunction. They need to know who to call to get these things replaced if they don't keep them in the home. And I think also making sure that the home to which this person is going and their caregivers have backup caregivers so that they don't become so exhausted they can't care for the patient. Seen this a few times in my career where the parents are just overwhelmed and the patient's caregivers are overwhelmed and they're just so tired they can't even take care of the patient anymore because sometimes they're a lot of work. And I think that if you help your caregivers make some kind of a little schedule for the person after they come home, this helps a lot because they know when things happen. And if you've got someone who comes home with a tracheostomy tube, a home ventilator, a gastrostomy tube, and tube feedings that have to happen at a certain time, and probably medications in between there. And this is a super simple one, by the way. Um, I think that you can make their life a whole lot easier if you can help them make a little schedule like this so they know when things are happening. Many people who go home who are completely disabled have home therapy. Actually, like here, this is a teacher comes. Some of them are homeschooled with the local school district. In some of the bigger school districts, they actually send teachers into the home. Now, a lot of them can actually go to school once they're stable. But this kind of gives you an idea of what to expect and when things are happening. So it really helps, it helps the family stay on track and not become overwhelmed. So how do families, patients, and caregivers find physicians? How do they find each other? They don't look up in a phone book. I mean, you can't do that because there's nothing in the phone book. Now we don't even have phone books, but you can look it up online, but you don't know what you got. If you Google something, can you be 100% sure that's correct? No. If you can go to some of the things like LinkedIn and I know the AOA website has something where you can find a DO, and the MDs have a similar thing where you can find a doc, but you don't know what it is and you don't know who that person is. So how do you do it? Well, it's pretty stressful anyway, but if you let people know that that's what you do, and that's not hard, all you have to take care of is one family who has a special needs person. That's all you got to do. They'll take care of it. They'll tell the world. You don't have to advertise it because they'll find out. They'll pick up the phone and call everybody they know. And if you let the local hospital where you happen to be practicing know that you care for people with disabilities, you will be inundated. This I can tell you from personal experience. How do families find it though? Well, I've always told them in the past, ask the people in the hospital that cared for your person. Ask the nurses, ask the physical therapists, ask other physicians that you may encounter. Maybe you're seeing an ENT for some reason there that's a senior person. Ask the ENT. Who can I see as a primary care physician once I get out of here? And that's how it works. And if that person happens to be in a hospital has a training facility for physicians, you can also find the person that's head of the training program and ask them if there's anybody in the community that they've trained recently who cares for people with disabilities. And a lot of times you'll be able to find somebody, at least you'll have a phone number that you can call. I always tell families you need to ask more than one person. Don't just find one person and go there. You need to ask a few people what their opinion is of Dr. Jones. What was their office like? How was their office staff? You just need to ask those kinds of questions. Is it an interview? You betcha. We're going to talk about that next. And you also need to make sure that whoever you do pick takes your insurance if you're using insurance. Well, what kind of qualities should a physician have to care for people with special needs? Well, you got to be smart. You can't be dumb. Well, you got to do medical school, so you're not stupid. But you got to be somebody you can talk to. You've got to have excellent communication skills because you are dealing with people who are off the charts stressed. All they're thinking right now is, oh my goodness, how am I going to care for this person who has everything wrong with them? Maybe that person's nonverbal. About 40% of my patient population was nonverbal. So one thing I think they need to teach in medical school is sign language. I think it should be required in medical school. I forgot most of mine, but I was pretty good at one point in time because we had the entire deaf community in our office. But I think that these are some things that caregivers need to know. It's got to be somebody that's available. What I always talk about was the 3 A's: affordable, affable, and available. If you're not those 3 things, you're not going to help somebody with a disability because you don't know when that you're going to be needed. I tell parents to go and interview. You're welcome to come to my office and sit with me. No, I'm not going to charge you. Now, there's some creeps out there that probably will, but it's worth whatever you had to pay to find out if you like them or not, if you can communicate or not, and if they have your person's best interest at heart, and you can take the patient with you. Now, sometimes you can't if they haven't come out of the hospital yet, but you owe it to the person that's going home to go and find out if these people can have a conversation with you. I always told parents to bring records, just a brief record of what's happened to their person before they show up to an interview, because you can't remember everything, and because this particular physician doesn't know anything about the person that they might get into their practice. Bring the insurance information, bring the patient's diagnosis. The meeting should last at least 30 minutes, and I think that the family and the physician needs to take notes. I'll get more on that in a minute, but I think whoever is doing the interviewing needs to make quite sure that the physician knows what their expectation is of how it's going to go. This is what I expect from you as a physician. And that's not being mean. That's just being upfront with people. And you should know as a physician whether you can deliver or not. I mean, there wasn't anything that came in my office I couldn't handle. I mean, it was ugly. Sometimes it was weird, but we did it. That's because we wanted to. Ooh, there's a word, want. I didn't do it for the money. I did it because somebody needed help and because somebody was not going to get care anywhere else. What are you going to do, turn them away? I don't think so. And also bringing a timeline, having the patients, caregivers bring a timeline so that the physician needs to know who's involved in this patient's care and how much are they involved so that they know what their role is going to be. Because the physician can't do everything. Because remember, we're stuck in offices with 50 million patients, a staff and the telephone. So we can't take care of everything. We need to know what they're able to take care of or what we can train them to take care of. Here's some things that this is a list I used to give parents all the time in the hospital. I said, take this list because, maybe I was actually seeing the patient in the hospital through the emergency department or something, and they were complaining that their doctor didn't listen to them. And so here's a list that you need to make a checklist of. And I said, it's not playing, some sort of quiz game with the physician. It's finding out what you need to know in order for your person to get the best care possible. And it's not a quiz show, but first things, how did they answer the phone? Did they seem interested? Or was it all automated? Ooh, run. You don't want automated. That doesn't help you in an emergency. And you're not going to go to the emergency department. And you're not going to call 911 for everything because you've got somebody in the house who 911 is not going to change anything. They're not in extremis. You just need help. It's not a 911 call. Did the physician come on time for the interview? If they made you wait for the interview, they will make you wait in the waiting room when you actually have to come to their office. And how long can you really wait with a child on a ventilator who needs suctioning every 30 minutes, or a patient who has immune compromise, or fill in the blanks? It's not good. Can you tell if they're interested or not? Could they answer your questions that you ask clearly? What do you do with phone calls for people with special needs? Who answers them? Well, I have to tell you, I had 8 years with no days off. I answered my own phone calls. Finally, Children's Medical Center came through and said, you can turn your phones over to us at night. We know when to call you. And they did. I got to sleep. My patients got good care. Do they need, when they finally do get to come to the office, maybe they always get to come to the office, how do you schedule them? Do you schedule them away from all the sick people? Do you have a sick and well waiting room? How do you handle sick people versus people with special needs? Oh, here's a big question. Is the office wheelchair accessible? How many people told me over the years, I would have gone to that physician, but we couldn't get the wheelchair in the door because it wasn't ADA acceptable. Or it was up on the 3rd floor and there wasn't an elevator. So special needs people can't do that. They can't use that office. Another question I always had my parents and caregivers ask is, does the physician try to reduce the number of medicines if possible when the person no longer needs them? Do they keep track of what medicines they're on? Do they have alternative ways to treat it? We do, we're DOs. Uh, but those are some questions I had them ask. And what do you do after hours? Who do you call? So then you have to, so you found a physician, you got lucky, you found some really cool person that's going to take care of your person. But um, looking at it from a physician perspective, I think you need to, because you're going to be physicians. You know, it's really time consuming. I'm the first to tell you, I did it for 40 some years. It's very time consuming. So you have to be able to multitask. You need to be able to know to whom to delegate certain tasks and understand that some of them cannot be delegated, okay, period. Um, you need to understand how to get quick communication with people and make sure that you, when you do interview these people to see if you want them in your practice, that you allow enough time for a reasonable interview. Don't sandwich it in between two well visits or sandwich it in at lunch or sometime when you know you're going to be crazy. I always did mine on after hours or Saturday morning before anybody got there. But I found that after hours was better because all patients were gone and all I had was the parents, caregivers, and maybe the patient. We could sit and visit for as long as we needed to. I have to tell you that most caregivers of people with special needs have never had their questions answered completely. And they're going to have a bunch. And you just have to be patient. Because in the hospital setting, and you'll find this out when you go to third year, there's not time for much of anything. You barely get the note written and see the patient. You don't have time for a lot of yakety yak. And yes, the attending should be doing that, but in the hospitalist sense, the only thing they know are people who are in the hospital because the majority of them have not done primary care. So they don't know what people who are going into primary care want to know. And they may not have time to answer all the questions. They may not know the answers too. And that's another thing. You have to be able to look stuff up. I usually have people sit, and I had, when I was interviewing, we didn't do it in a patient room. We did it in a place where we could sit down and relax and take notes. And I tried to tell people when I had former students want to do this, make sure you take notes, but don't let it distract from eye contact with the people that came to see you. And I'll tell you, if anything feels weird or if the hair stands up on the back of your neck or you get a creepy feeling, take that patient. Don't take it. Don't do it because you could be in for some trouble. Here are some things you need to ask the people that come to see you. What's going on. If they can't answer these questions, or they can't answer most of them, they've not been there and they haven't paid attention to what's going on. They may not know complete answers, but they should at least know discharge date, what the diagnosis is, when the patient might go home, and this sort of thing. If they don't know any of that, then they haven't been there. And those are some other people that you may not want in your practice. Let me go back just for a minute. I'm trying to think. In almost 43 years, I only refused 2 patients, 2 out of thousands. Why? Well, one of them came in for the interview and 2 cop cars showed up as they were walking in my office. And I'm like, ooh, better not get this one. The other one turned out to be a little bit flaky. I took them anyway, and I finally had to let them go because it was Munchausen syndrome by proxy. You'll learn about that. People who make whoever they're caring for sick to make them look good. And that one went away. They ultimately came back to me through Child Protective Services. But those are the only 2 I ever let go. But if they come in with cops follow them, you don't want them. It's just note to self. So who else is on the team? So you got a physician now who can run the show. And here's some things that the patient might need. They might not need all these things, but they probably will need at least one of them. And the parents and caregivers have no idea how to get it, because they never had to do it before. So it'll be part of the plan when you sit down with the family and organize, what do we do next? Some of these things have to be put in place before the patient even considers going home. Home care companies. Some of those home care companies do everything. They do nursing, physical therapy, occupational therapy, speech. They do everything. Some of them don't. It depends on where you live, and that speaks to demographics. If you're in a big city, you got probably no problem getting all this stuff. If you're out in the middle of nowhere, where I practiced medicine for a long time, it's not that easy. And in fact, sometimes there are things there that you cannot get, that you have to figure out how to make work without a specific agency. If you're the managing physician, you can kind of tell the parents and caregivers, hey, use this agency. They're really good. They take your insurance. Let me make a call. It should come from the physician, not the family. Family doesn't know how to order stuff. They may learn, but if it doesn't come from the physician, it's not legit. So remember that. And sometimes there's going to be a time when, even though you have a good nursing service and you've got nursing care set up for some patients, they might not be available because, somebody got sick, they overbooked, whatever. There's always sometimes a glitch, not often, but that's when you have to make sure that your family has a backup plan for who's going to care for the patient. Still interested? You see how much work it is. Equipment. Yeah, let's talk about equipment. Some people require a hospital bed, a suction machine, a home ventilator, an IV pump, another pump for the NG, nasogastric feeds. Maybe they have a urinary catheter. Maybe they have a portacath that has to be flushed every now and again. They can have all those things and still go home. Wow. You can't just show up at home and need all those things without some prior thought to this whole thing. Especially things like hospital beds. They've got to be ordered, and they have to be ordered. Sometimes it takes a couple of weeks to get some of this stuff. So as soon as the hospital starts mentioning discharge, you need to make sure that you've got a correct date that they might go home, and also make sure that the home care gets called immediately so that they know to get all these equipment that they might need. Also, disposable supplies. They may need underpads, they may need diapers, they may need dressing change kits and this sort of thing. And you need to make sure that the insurance company is going to pay them, because they will not deliver without being paid. Pretty much anywhere. You can't go buy groceries and not pay for them. Same. It's the same thing. What about a pharmacy? Oh, sadly, most of these people go home on medicine, and some of them need it every 2-3 hours. Some of them just need it twice a day. Some of it's IV, some of it's by mouth, some of it's by nasogastric tube. Pharmacy's got to be chosen to make sure, again, that they take your insurance. They got to make sure that they have availability for the medicines that the patient's being sent home on, because some could be really weird, especially some of these biologics. You can't just get that at Walgreens. Sometimes you have to go to a specialty pharmacy to get some of these things that people go home on. If you have a pharmacy that delivers, that's even better, because that way nobody has to leave the house to go to the pharmacy. And you need to find out if the pharmacy that the family chooses is going to be able to deliver the medicines that the patient needs. When you write prescriptions for these medicines, and it's all done electronically now, make sure you give them plenty of refills. They don't want to bug you every 2 weeks for a refill, especially if it's something that patient's going to be on for a long time. It's crazy. Obviously, controlled substances are different. Not a whole lot of people go home on those. A few do, especially if they're going to hospice care, but that's a whole nother lecture. And also, be sure that as a physician, you have good communication with your pharmacy. So when a medicine is started and begun or stopped, that actually happens. How many times have I seen people coming into my office from somewhere else and be on 6 or 7 different things, and 5 of them were supposed to be discontinued, but they're still on them. And can especially remember a young man coming in with his mom with a Ziploc bag full of medicine, And she says, I just want him to wake up. And that's because he was on about 7 things that were sedating and they'd been discontinued, but mom didn't know to stop them because nobody told her to stop them. So she kept giving them because she was being a good mom. And poor child, he was asleep all the time. Woke up, he was pretty cool, but that kind of stuff happens, believe it or not. Making sure that you've got a case manager at the insurance company, and that's on you. That's on the physician. The parents may not know. The caregivers may not know. Family may not know. They know they've talked to somebody at the insurance company, but they don't know who it is. They don't have a name. But you need a person that you can call and say, hey, I need your help. This patient needs XYZ. It's a whole lot easier than, if you've ever called anybody here ever called an insurance company? It's like calling God. You get put on hold, then you have to go through 27 different people, and you have to tell your story 27 times. Who wants to do that? Nobody. And if it's a physician, you don't have time for that nonsense. So this is why you got to find out who the case manager is. And you need to call them and say, hey, Johnny Jones is doing very good. Just wanted you to know that. Or Johnny Jones has got a problem. He's going to need a different wheelchair or a different assistive device so he can walk again, this kind of stuff. The only way they know that is for you to call them. And you can't make your office staff do that stuff. You have to do it yourself. Oh, here's some things that you might not have even thought about. Regardless of where they're going home, even if it's a huge city, you need to contact the EMS system near where this patient lives and let them know that in their vicinity is a person with special needs. You may never need them, but they need to know the patient's there. And that way, if they get called, they'll look at their list because they all keep lists. I know my son is a firefighter, EMS, up in Denton, and they have a list on the wall of who in their area that they cover has special needs, is on a ventilator, whatever. So that if they get that call, they can look at the list and they already know they're not going to be intubating anybody. They got a tracheostomy and they already know what the diagnosis is many times. So it's just good, and it keeps them from freaking out, and it keeps the patient safe. That way they can give the most appropriate care. If they're going home on hospice, and we got a whole nother lecture on that, but if they're going home on hospice or with possible death, that's a whole different thing.